Okay, so this is chapter 6, starts on page 144. This is caring for the woman experiencing complications during pregnancy. So I have some little acronyms over here, abortion and rope. You can read through those. It's just talking about assessing the pregnancy test, bleeding, on bed rest, review the procedure to assist with the ROGAM that we'll talk about, the term miscarriage, instruction to the client regarding questions and procedures, omitting any vaginal exam, omitting falls, and then noting how much tissue passed away. And then the rope is the RHD, immunoglobulin, which is the ROGAM, oxytocin, analgesics, antibiotics, and prostaglandins, and vaginal suppository. So it's just a little acronyms that may be useful. So let's go over to the book. Just some keywords here. Let's talk about ectopic pregnancies. Okay, so ectopic pregnancies happen when the fertilized egg implants anywhere other than a uterus. Okay, it can be the cervix, fallopian tube, abdominal wall, on the bowels, and there are a number of factors that play into this, and they're listed in these bullet points here. Okay, so be sure that you understand that. A ruptured ectopic pregnancy is an emergency. Okay, it can cause hypotension, bleeding, any rupture that could cause death, morbidity, mortality, death to the pregnant woman. Okay, be sure you're familiar with that. On page 146, it starts talking about the management of these. Salpingectomy, which is the removal of the fallopian tubes. Methotrexate, which is a drug that inhibits that growth to continue, and it's here. Just make sure you understand those terms. And then let's talk about gestational trophoblastic disease. Okay, this paragraph is a wink and lollipop. This used to be called a molar pregnancy. Okay, and it can cause cancer, choriocarcinoma. Okay, their stomach grows. They have the hydroform mole or the molar pregnancy, and this happens in 1 in 1,000 pregnancies. Okay, now it's termed gestational trophoblastic disease. Okay, it's where the chorionic villi degenerate into a mass of like grape-like clusters. Okay, the pathophysiology, this paragraph is a wink and lollipop. Okay, the cause is unknown. Okay, there is no reason that's been found that this happens. Choriocarcinoma is imminent, and it can be fatal. So it's invasive cancer that happens after or with this molar pregnancy. Okay, some signs and symptoms that you need to know are more than 95% of patients experience vaginal bleeding. So if they see this, then that could be a sign that this is that GTD or that molar pregnancy. Okay, it may be scant, it may be profuse, it may be bright red, it may be dark brown, but those molar pregnancies, the tissue does look like grape clusters. Okay, resembles grapes. So make sure you understand what the gestational trophoblastic disease is. Patient education, when it concerns this, is that they must avoid pregnancy for at least 1 year. They need to be on birth control, some type of birth control where they do not get pregnant after 1 year. Their body needs to heal from this type of pregnancy. That's not really a pregnancy, but We don't want them to get pregnant, okay? Page 148 starts talking about the management of spontaneous abortions. If a woman has a blood type that is negative, so any type, A negative, B negative, AB negative, O negative, when they're pregnant, they must receive RhoGAM, okay? It's very important because it desensitizes for her next pregnancy. Incomplete, inevitable, missed abortions are usually managed by D&C, which is dilatation and curettage, where they go in and scrape with a curette all of the tissue that's on the uterine wall. But they do need to receive that RhoGAM shot, okay? It's very important that they receive that if they are any type of negative. So let's go in talking about HCG levels. This is in your book on page 148. The initial testing, and then it goes up. Ectopic pregnancies don't go up as high as a normal pregnancy does, okay? So that may be a telltale sign that you have an ectopic pregnancy. Of course, when you have a spontaneous abortion, a miscarriage, those HCG levels will drop, which is another telltale sign that something is wrong. There's something called cervical insufficiency, and this is where it's the inability of the cervix to stay closed, okay? So we have something called a cerclage that can be done. There's a couple of different types, the McDonald and the Schachter, and this is where they actually sew the cervix closed. Usually about 37 weeks, they'll go in and remove that suture to facilitate birth. But women with insufficient cervixes will have this done, and it helps to keep the pregnancy viable. Hyperemesis gravidarum is where you have severe nausea, vomiting throughout the pregnancy. You can read through that here. Bleeding disorders later in pregnancy, 3 to 4% of all pregnancies may have this. Some can lead to death, and some it's just like a cervicitis or benign issue like a laceration on the cervix or a nicked capillary. Box 6-1 is a wink and lollipop. Okay, you need to know this box here. Okay, wink and lollipop. You need to know what drugs, common medications are used for nausea and vomiting during pregnancy. Our big guns are Phenergan, of course. Phenergan is our one of our main nausea vomiting medications. What's another one? Like Zofran. It's not listed on here, but that's another big one. Dramamine, diphenhydramate, and then metoclopramide is our Reglan. Those are our big ones, okay? B6 is also used. So Unisom and the doxylene succinate, Diclegis, which is our pyridoxine hydrochloride. Placental causes of vaginal bleeding. Did I say this was a wink and lollipop? Remember, you need to know this box, okay? Alright, so let's talk about placenta previas. This is on page 149. Placenta previa is where it happens in 1 in every 200 pregnancies. And you have pictures in your book, so let's go down here and look at these. Placenta previa is where the placenta attaches to the uterine wall anywhere other than where it should be, okay? So complete previa, there's 3 different kinds. There's complete, partial, and marginal or low-lying, okay? So a complete previa is where the placenta attaches to the uterine wall over the cervical opening. The partial is where part of it is attached over the cervical opening, and low-lying is where it's just right next to that cervical opening, okay? Can we have a vaginal delivery with a placenta previa? Absolutely not, okay? We cannot deliver placenta and then baby, because we know this placenta is our lifeline for our baby, right? Our fetus. So we cannot deliver placenta and then baby. So these women will have to have a scheduled C-section. All right. Go back and look at some signs and symptoms. Up here, this paragraph is a wink and lollipop. So you need to know the signs and symptoms of a placenta previa, okay? The biggest, most common sign is painless, bright red bleeding. So they will just bleed, bright red bleeding. No pain, really. But this is where this placenta detaches from the uterine wall. It starts detaching and they see this bright red bleeding, okay? All right, let's talk about the vasa previa. Okay, this is where the umbilical vessels are not supported by the cord. You can read through that. The Klein-Hauer-Beck is a blood test that's ordered to determine whether or not the maternal blood and fetal blood have mixed. Okay. They see whether or not the ROGAM should be administered. So if they have a placenta previa that abrupts or ruptures, then they would need to receive that ROGAM, of course, during that stay, because those types of blood have mixed, and that's called Klein-Hauer-Beck. Okay. Going on down to placental abruption, which is abruptio placentae, is the premature or immature, complete or partial separation. Okay, so let's go down here and look at it. This happens in up to 5% of women that have mortality. Okay. The fetal mortality is much, much higher. Okay, it occurs in about 35% of the fetuses. So placental abruption, or abruptio placentae, is when this starts separating. And you can see here the placenta is less than 15% on a mid-grade hemorrhage. And a moderate is where it's up to 50%, and then severe is where it's greater than 50%, okay? And it can be concealed. But what happens? This is separated, so are we getting oxygen? Are we getting nutrients to our fetus? Absolutely not. We cannot have a placenta that is separated and get the support and nutrition and oxygen blood supply to the fetus. That's why this rate is so high, okay? But you need to know those 3 grades. So grade 1 is slight vaginal bleeding, grade 2 is moderate, and grade 3 is severe. This is very, very painful to the mother. This one is. So we know, we went back up here, right? And the placenta previa is not painful, painless, right? But placental abruption is very painful, okay? Hemorrhaging, very, very painful. What can elicit this? We learned a while ago that cocaine use can elicit, I left off the E. Cocaine use can elicit a placental abruption. Okay. Signs and symptoms, depends on the degree of it, but wink and lollipop again here in this paragraph, that the management depends on the degree. Okay. Rapid potential deterioration can be DIC. Please understand that that's important. Wink and lollipop, that DIC can be a sign and symptom that there is a placental abruptio placentae happening. Okay. Box 6-3 on page 152. Caring for a woman that has abruption, abruptio placentae or placental abruption. This box is a wink and lollipop. Okay, you need to have a huge IV going for her. She's probably going to be receiving packed red blood cells, all the things. So we don't need a 24 gauge, right? We need a 16, 18 at the smallest. You know, the larger the number, the smaller the needle, right? So a 16 gauge is pretty big. This is what we use when we have blood donations. Okay. So we need a large bore catheter going for her. This is a priority. So you should write priority out beside here. Okay. Lab work. Preterm labor is what we're talking about next, and some lab work that goes with that. There's something called a fetal fibronectin, and this is a glycoprotein that's produced by the fetal membranes to show is it actually working. This is usually done about 17 weeks, 16 to 20 weeks. A positive result can indicate that labor may start. So this is just like showing the glue that holds everything together, that holds the pregnancy together. If it comes back positive, that means that there's not enough of that substance, the glycoprotein, to keep her pregnant. So we always want this to be negative. Make sure you read through that. Table 6.4 is talking about the different various risks for preterm labor and birth. Make sure you read through that. There's social, personal, economic, pregnancy-related, fetal conditions, and behavioral, of course. And we know the big substance abuse is a huge factor. Okay, smoking is a huge factor. You can flip to page 256 if you want to, and there's some more preterm labor labs that are listed there. We'll talk about those later on. This is a picture of the placenta previa that's from your book. Just some rest. Of course, she would be on bed rest. Okay. And this is the abruption pictures that are from your book. Another thing about, let me go back up here to abruptio placentae. She's going to have a board-like abdomen. Okay. And you note that here, board-like abdomen. It's very tender, very, very painful. She's going to see some dark red vaginal bleeding if she bleeds at all. And you'll see sometimes when it's just the grade 3, it's all concealed, but it's very, very painful. You're going to see your biggest sign is abdominal pain and fetal distress. Your heart rate's going to go down in your baby, your fetus. The maternal heart rate's going up. BP, of course, because she's hemorrhaging, it's going down. Okay, so it would behoove you to know this acronym right here. Okay, very important. All right, let's go back to page 154. All right, so there's a term that we use called tocolysis or tocolytic therapy. This is where we use a drug or procedure to stop or slow down the labor. Okay. Magnesium sulfate is our big gun. Okay, we use this for preterm labor. We also use this for preeclampsia. But preterm labor, especially if they are less than 34 weeks, we want to slow those contractions way down. Nifedipine is another one. It stops calcium channel blocker. Of course, it's a peen, if you remember that from pharmacology. It uses blocking agents to stop that cell membrane, the calcium ions in that cell membrane. Okay, smooth muscle activation. So nifedipine with magnesium sulfate can cause cardiac arrest. Please never, ever, ever give magnesium sulfate with nifedipine. Okay, huge no-no. Wink and lollipop. Never, ever, ever use nifedipine with mag sulfate. Going back up here, it talks about mag sulfate as a CNS depressant. We will talk a lot about mag sulfate in the future. All right, so let's go to premature rupture of membranes. We also call that PROM. Okay, premature rupture of membranes. Okay, and it has to meet these three criteria. So it's premature onset of labor, rupture membranes before 37 weeks, rupture before the 37th complete week. That would be considered premature rupture of membranes. Okay, so if it's 36 weeks and 6 days, 36 and 6, that would be considered what? PROM, premature rupture of membranes. Okay, there's different signs that we will see when this happens. Of course, the mama can get sick. Okay. Evidence for that's labor, chorioamnitis. Okay, this is an intrauterine infection. You're going to see a temperature increase with this. This is an infection of that uterine lining. Okay, if you've ever smelled C. diff, this is very comparable to C. diff. It's a smell that you won't forget. So if I say the term chorio, you know that's what I'm talking about, chorioamnitis. Okay, she's going to spike a fever. She is sick, so she's going to have to be on antibiotics. We're checking her temp. Anytime that her water breaks sooner than it should puts her at risk for chorioamnitis. Okay, if she has not delivered within the first 24 hours after her water breaks, and this is for anybody at any time during their pregnancy, she must go on antibiotics to prevent this chorioamnitis from happening. This is just a little chart of things that we were talking about earlier, which is, I really like this chart. Kind of shows you the different things that happen. Okay. All right, so let's go to page 156. Hypertensive disorders during pregnancy. So we have chronic hypertension. We know is what? This is, you were diagnosed before you got pregnant or before 20 weeks. Just regular, good old-fashioned hypertension. Okay, you got a diastolic over 140 and a systolic over 140 and a diastolic over 90. And then you have preeclampsia. Okay, this is defined as the increase in blood pressure plus protein. It's not just gestational hypertension. Okay, gestational hypertension is kind of like when we talked about gestational diabetes. It's just hypertension that has happened during pregnancy. Preeclampsia, however, is different. It's accompanied by that proteinuria, the excretion of protein in the urine. Okay, we check that with lab draws. We check that, of course, with urine dipsticks. And then you have eclampsia. Eclampsia is when there is a seizure, a grand mal seizure during pregnancy. So, of course, preeclampsia is before the seizure, right? We have everything that's going on that can happen to cause eclampsia. But eclampsia, please understand, eclampsia does not happen without the activity of the grand mal seizure. Eclampsia is the grand mal seizure due to blood pressure and proteinuria during pregnancy. There's a very, very good pathophysiology explanation in your book that I want you to read through, okay? It's these paragraphs here. It makes sense. The book did a very good job explaining that. And these are just different complications it talks about over here. The preeclampsia, eclampsia, and HELP syndrome. We're going to talk about HELP and DIC, but HELP is hemolysis, elevated liver enzymes, and low platelet counts. Assessment tools. Here's another acronym that I want you to know, and I want you to add some to this, okay? I want you to add, this is some winks and lollipops, okay? So you need to know these. I want you to know to check the DTRs. I also want you to implement seizure precautions. So these should be written in your book. And check the neurologic status. So this is something that you need to write in your book, Winks and Lollipops, okay? Make sure you understand that. Well, let's see. All right, so classifications on page 157. Let's go back. You got the note here, right? Risk factors, classifications, another wink and lollipop. Okay, so classification of preeclampsia for maternal and fetal morbidity and mortality. These are winks and lollipops. Okay, know these bullet points. Know the risk factors. All of this, winks and lollipops, okay? Make sure you understand that. I want you to also add some for preeclampsia. So let's add a note. So for preeclampsia, you've got some cerebral manifestations. Such as headache and dizziness. Then you have GI assessment findings. I'm abbreviating. And this will be what? Epigastric pain. So you're going to see epigastric pain during preeclampsia. That's another sign of it. And then you're going to see DTRs increased. And of course, increased what? Blood pressures. So make sure you understand all of those. Alright, so you got cerebral manifestations, which are headache and dizziness, gastrointestinal assessment findings, epigastric pain, and then DTRs, your deep tendon reflexes, are increased, and then of course your increased blood pressures. So when I go in and I start assessing somebody for preeclampsia, I'm asking them, have you had any headache, blurred vision? That's another one I didn't list up here, but that's one. Blurred vision, dizziness, epigastric pain. Okay, those are huge. I keep messing up this book. I'm sorry, y'all. Okay, back. So make sure you understand that those, and I just highlighted this to be able to get a note, but those are different signs. So headache, blurred vision, dizziness, blurred vision I didn't have, but dizziness, gastrointestinal, like the epigastric pain, DTRs increased, and blood pressure increased. So we give a drug. And what did I say we give for preeclampsia a while ago? Magnesium sulfate, to diminish all of these. It lowers the blood pressure, lowers the deep tendon reflexes, and we know before you have a seizure you have hyperreflexia, right, which is increased DTRs. So we diminish those by giving the magnesium sulfate. So it slows everything down. So what else do we need to be checking? Respiratory rate. Okay, so we're listening to her. We are checking DTRs, we're checking blood pressures. Anytime anybody's on magnesium sulfate, we're doing all of those. Okay, and then your book on page 157 has a little chart. It's up here. Yep, right here. I told you need to know these. Okay, and then this talks about the blurred vision here. Alright, page 158 is management of preeclampsia or eclampsia. Okay, make sure you read through this. Home management listed here. Visual changes, not feeling right. They need to let their doctors know. Okay, and then of course it goes on page 159 that talks about the different drugs that can treat severe hypertension during pregnancy. Okay. Nifedipine is one, but do we give this with mag sulfate? No. Because it can cause what? Cardiac arrest. Okay? That we just discussed. Alright, so I want you to just be familiar with those drugs on, let's see. There's right here. Seizure prophylaxis with magnesium sulfate has been our drug of choice, wink and lollipop, okay? Because it acts as a CNS depressant. All right. Page 160 goes into detail about mag sulfate. Please understand that this is a wink and lollipop. You need to know all the things you can about magnesium sulfate. This is our big OB drug, okay? You need to know this as a wink and lollipop, okay? Know this magnesium sulfate box. This is on page 160, all right? And what did I just tell you you need to be checking for? Respiratory rate, right? So, an adverse effect, of course, is decreased respirations. So we're listening to her every while she's getting her bolus, which is a 40 gram bolus, and then she usually gets 1 or 2 grams an hour. 44 grams, not 40, 4 grams, and then she gets 1 to 2 or 1 to 3, it says, an hour. So she gets a 4-gram bolus over the first 30 minutes or so, and then we give her the 1 to 3 grams. It's usually 1 to 2, unless it's severe, of the mag sulfate. Okay. There's some things in here that are very important. So number 6, monitor that neurostatus, right, before and after therapy. So how do we know what a baseline is? We know a baseline is what we have before we start a drug, right? So we need to be checking her DTRs before we start the mag sulfate therapy. Are her DTRs already +2? And that's where we want them, right? You're not going to see +3. You're actually, when you start the drug, you're going to see +1 or diminished. So it's very important to have that baseline. Number 12. Go ahead and memorize this. Your antidote for magnesium sulfate is calcium gluconate. So anytime you have a patient on magnesium sulfate, you should have calcium gluconate in your pocket. Because if you walk in and she's breathing 5 times a minute and her DTRs are diminished, like no reflexes at all, then you need to call your primary care physician, your OB, whoever's the ordering physician, and let him know that. He's going to order a stat mag sulfate level, and probably go ahead and tell you to give some calcium gluconate. Okay, it's very important that you have that on your person anytime you have somebody on mag sulfate. Okay, all right. So optimizing outcomes, another winks and lollipops. Okay, this paragraph here. Make sure you're doing these daily assessment of somebody with preeclampsia. Okay, memorize these. You're going to see edema. You're going to see maybe some tachycardia, some poor skin turgor. Cap refill might be greater than 3 seconds. So make sure you understand that. And then mag levels. So therapeutic is 4 to 7. When I was a labor and delivery nurse, anything over 7 we started becoming concerned about. Okay, I had shipped a patient, rode on a transport. We took her from Tifton to Macon, and her mag level came back 11. So they had pushed a lot of it before I got to her. Shift change happened, and I was ordered to have her shipped. So I went with her, and it was 11. So of course we turned the mag sulfate off, right? I watched her closely. She was safe, and then we ended up not doing calcium gluconate, but I think they gave her a low dose when I got her to the level 3 hospital in Macon. Just because they did not want any respiratory distress or cardiac arrest. So and that's exactly why we shipped her, because it was too much for the level 2 hospital I was working in. It starts talking about significance of proteinuria, edema, the CNS alterations. You can read through that. And this preterm labor. Going back to talk about preterm labor, betamethasone, and we'll talk about this a little bit later, but betamethasone is a drug that we give for preterm labor. Terbutaline. Betamethasone is it increases the LS ratio, which this is the surfactant that the baby has. So it's a glue-like substance that the fetal lungs produce. And it's important when the baby takes the first breath after birth. This glue holds that alveoli open. Okay, it holds the tissues of the alveoli open. So it's like a glue. And once they take that first breath, the glue kind of dries, and it keeps those little pockets of air open where they can expand or retract. Okay, Terbutaline sulfate, brethine is the trade name. We use that to stop preterm labor. Okay, just like we use mag sulfate, we use terbutaline as well. But terbutaline can cause tachycardia. Okay, so we need to make sure to keep a check on mom's heart rate. On 163, there is a case study. I always suggest that you do these case studies. We may go over some of these in class, so make sure you understand and can answer these questions here. All right, let's talk about HELP syndrome. All right, HELP syndrome, like I said earlier, was an acronym for hemolysis, elevated liver enzymes, low platelet levels. Okay, this can happen due to the preeclampsia. You're going to see the same types of symptoms. Okay, so nausea, vomiting, epigastric pain, vision problems, headaches, renal and liver failure even. Okay, DIC, we'll talk about that, but this is a result of the arterial spasms of the cardiovascular system. But this is HELP syndrome. It centers on improving the platelet count. So I think I have and this is our little preeclampsia song if you want to sing that. It's attuned to achy breaky heart. Okay, decrease BP, decrease PP. These are toxic signs of mag sulfate, drop in respiratory rate, patellar reflex thereaned, give antidote, calcium gluconate. And then there's risk factors. And then everything in the book. All right, so this is HELP syndrome, okay, and DIC. I think I have something that compares these. I'll give you a handout in class. Okay, so HELP syndrome, hemolysis, which we know as the breakdown, right? This is the breakdown of red blood cells. Okay, so you're going to see anemia and jaundice, elevated liver enzymes, so our AST and ALT are elevated, and then of course our low platelets, less than 100,000. Thrombocytopenia, abnormal clotting time, even petechiae, bleeding gums. This is where they're bleeding from every orifice. Okay, their eyes can even bleed, their ears can bleed. It's very, very bad. There is no clotting factors. Okay, it's like Coumadin times a million. Okay, warfarin times a million. Lots of headaches. Nothing is clotting. DIC is where there's too much clotting. Okay, there's so much clotting, large amount of clotting factors, and the most common cause in pregnancy are excessive blood loss. Okay, so when they have the placental abruption or severe preeclampsia, HELP syndrome, it over clots. Okay, and it depletes those platelets. This is very, very critical. So you're assessing again for the bleeding. Because it's over clotting, it's used all of our platelets up. Okay, we're watching for fetal distress, we're watching for oxygen depletion in the mom. So, but we'll talk more about this in class. Different reasons that cause it. Okay, so sepsis, peripartum hemorrhage, of course, like the abruption or the previa. Severe hypertension, retained stillbirth, because remember that the body's trying to get rid of that, and it's clotting so much that it's used all the platelets. Amniotic fluid embolism and acute fatty liver. Treatments would be blood transfusions. Okay, our D-dimers are going to be out of whack. Our PT, PTTs, thrombin times out of whack. You're going to see that patient bleeding too. So just because they're overproducing those clots does not mean they're not going to bleed, because remember, it's used all of our platelets up for clotting, over clotting, and so they start bleeding. Another weekend lollipop is the nursing care paragraph. Okay, so nursing care includes watching for bleeding, right? Make sure you understand that. All right, I'm going to pause here and do a part 2 of chapter 6.